Hello, good morning, good afternoon, and good evening to all our speakers, chairs, and the wonderful audiences in different parts of the world. Welcome to ACNS webinars. The speaker for the first session of today is our honorable guest from Germany, Professor Jürgen Beck. Prof. Beck is a chair in the Department of Neurosurgery and Speaker Neurocenter at the University of Freiburg, Germany. His clinical practice is focused on brain and interspinal tumors, vascular, skull base, and spontaneous intracranial hypotension and epilepsy surgery. His interests are focused on neuro-oncological molecular imaging, quantum magnetic imaging, and translational research. He is the head of the CSF Center, Freiburg, as well as intracerebral hemorrhage and cerebral vasospasm. He is the founder of the CAST and the first SIH boards in Switzerland and Germany, and he was a pivotal member in the AWMF guidelines writing for ICP, SIH, and brain abscess. He is the national EANS delegate and the member of the EANS vascular and CSF section. We are extremely grateful to him for accepting our invitation to be speaker at our webinars, and today we'll be talking about surgical management of spontaneous intracranial hypotension. The speaker for the second session of today is our honorable guest from China, Professor Wang. Professor Wang is a chief physician and doctoral supervisor and deputy director of the Cerebrovascular Disease Center and Stroke Center in the 3rd Hospital, Peking University, Beijing, China. He is also a visiting professor at the Westmead Hospital, University of Sydney, Australia. He is the vice chairman of the ischemic stroke surgery branch of the Stroke Expert Committee of National Health Commission of China and Cerebrovascular Diseases. He is on the editorial board and a reviewer for around 13 academic journals. His expertise is in the management of complex cerebrovascular diseases, especially carotid endarterectomy and carotid body tumors. In fact, he is the surgeon with the highest annual surgical volume for carotid body tumors in the world. We are extremely honored to have him today at our webinars, and today we'll be talking about complex extracranial bypass techniques and indications. The chair for the first session of today's webinar is an honorable guest from the United Kingdom, Dr. Lalani Carlton-Jones. Dr. Jones is a consultant neuroradiologist at the Guy's and St. Thomas NHS Foundation Trust, the Evalina London Children's Hospital and King's College Hospital NHS Foundation Trust. She also holds the post of Honorary Senior Clinical Lecturer, IOPPN, School of Neurosciences and King's College London. She serves as a visiting professor in SIH and spinal CSF leagues at the University of Hospital, Freiburg, Germany. And she is a member of several internationally acclaimed bodies in neuroradiology, and she is a founding member of the International Society for Spinal CSF Leaks. And her clinical interests are focused especially in the management of spinal CSF leaks. She has published extensively on this subject and in several reputed peer-reviewed journals. We are extremely grateful to her for accepting our invitation to chair the first session of today's webinar. The chair for the second session of today's webinar is our honorable guest from Japan, Professor Tomo Ichinose. Prof. Ichinose is an associate professor in the Department of Neurosurgery at the Osaka Metropolitan University, Osaka, Japan. He is a member of the Japanese Neurosurgical Society and the Japanese Society of Surgery and Surgery for Cerebral Stroke. His clinical interests are focused on cerebrovascular neurosurgery, especially carotid stenosis complex and bypass. He is also an authored author with several publications in various peer-reviewed journals, and we are extremely grateful to him for accepting our invitation to chair the second session of today's webinar. On behalf of the Education Committee of the ACNS and the President, Prof. Yoko Kato, I would like to welcome both the speakers, chairs, and the wonderful audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Professor Shubin for broadcasting this webinar on the WeChat channel. Dr. Libun Singh from Malaysia is my co-host for today, and with that introduction, I would like to hand over this online podium to our first chair, Prof. Lalani Carlton-Jones.
Well, thank you very much for the introduction. So I'm here really to introduce the star of the show, which is Professor Jürgen Beck. And he's going to be talking to us about the surgical management of spontaneous intracranial hypotension, which has gained a lot of traction and interest over the last decade in particular. And Professor Beck is really one of the pioneers of this field. He has pioneered minimally invasive techniques for the surgical management of spinal CSF leaks, which have been internationally adopted throughout major expert leading CSF leak centers, and publishes high volume, important practice changing work in this field regularly. He is a mentor to many in the field and is also a founding member of the International Society of Spinal CSF Leaks, which you'll hear more about in the next few months coming soon. essentially, I understand we have a predominantly neurosurgical audience. So spinal CSF leaks are essentially a neurosurgical disease. So I'm going to hand over now to our expert to talk about the surgical management of intracranial hypotension.
Thank you so much. Thank you so much for the Asian Council, and thank you so much for the really kind introduction. And I'm honored, and on behalf of my team in Freiburg, and also together with Delani, to be here. So I will give you a rough overview over spontaneous intracranial hypotension, which is clearly also a neuroradiological disease, and neuroradiology had made the difference in the last decades. What we are talking about is a headache syndrome, and the hallmark of the disease is orthostasis, meaning that you have a headache while sitting up or while standing, and in the beginning immediately getting better and relieved while lying down. Usually women are more affected than men, and the headache typically is rather in the back of the head and also in the neck. And just to give you also a rough overview where we are. So we are in Europe, in Germany, in a small village here, which is called Freiburg, at the border to France and at the border to Switzerland. And it's a cozy place where I'm working. It has only roughly 200,000 inhabitants. So a very, very small city as compared to the Asian metropoles. And this is our center. We have our own dedicated neuro center, which again might be very small for Asian standards, but in Germany it's one of the biggest, or the biggest one, with 6 neurosurgical theaters every day, and a special focus on high-tech imaging and CSF. Of course, the data I'm presenting to you are somewhat biased because we are a referral center for patients with spinal CSF leaks, and we see roughly 500 patients a year. I did over 450 meantime surgeries, minimal invasive surgeries, and together with Horst Urbach and Niklas Lützen, we perform roughly 200 blood patches a year. Just the basics. Spontaneous intracranial hypotension, the hallmark is that to have a CSF leak somewhere along the spinal dura. Okay, it's a spinal disease. And then you can see that once you have this leak, CSF is kind of oozing out into the epidural space, and the brain loses its buoyancy. It's kind of it sags down to the skull base, and there's a brain sagging, and it's tearing on veins and cranial nerves, basically explaining all the symptoms you have while standing up during orthostasis. So the origin of the disease is spinal. It's a spinal CSF leak. The symptoms is in the beginning almost always orthostatic headache, and a little bit more centered at the center of the head or the neck. And you also have vestibular cochlear symptoms, tinnitus, you feel like being underwater or having a hangover. The US and UK population is describing it very good as brain fog. There's also cognitive deficits associated with the disease. And you can even decrease further and into coma and even die from SIH. And there is still a big misunderstanding how prevalent the disease is. The disease is as often, and the incidence is as high as the incidence of subarachnoid hemorrhage. So roughly 5 per 100,000 people per year. And affected patients, they complain that they have lost their lives. It's not just a headache. They are not able to work, they lose their families. And many family practitioners and even neurologists around the world see the other side. So it's just a headache, rest, drink, wait, and it will subside. But usually it doesn't subside on its own. It's a severe disease and severely affecting many patients that are undiagnosed and underdiagnosed. So that's why neuroradiology is really the game changer in this disease. Now, approaching the surgical strategy slowly, we have at the level of the spine, there's the origin of the disease, meaning spinal leaks, and we have identified major type of leaks, 3 types of leaks over the last 20 years or so, which are ventral spinal leaks. There's almost always, or has been, a tiny little microspur cutting the dura on the ventral surface like a knife, and CSF is oozing out. Then we have type 2 lateral leaks, where there is also a tear in the dura, and there's an outpouching of arachnoid just below, usually below the Extracranial nerve root along the dura. And the classification is from Walter Schieving, and also he discovered only 10 years ago, imagine, only 10 years ago, a third type of a CSF fistula, which is a direct connection from the CSF space to the vein. So it's a CSF venous fistula. This is the imaging of these three types I'm referring to now in the talk, and I'm telling you how we approach these leaks surgically: the type 1 ventral leaks, the type 2 lateral leaks, and the type 3 direct CSF venous connections. But before you can go ahead with surgery, you need to diagnose the disease. And this is the first and biggest and most important step, because many patients go along undiagnosed. And there are prototypical signs on imaging. And in the contrast-enhanced MRI, you can see all these classical signs, the seeps, you see subdural collections, you see enhancement of the meninges, and it's a smooth and overall enhancement of the meninges. So it's completely different from meningiosis carcinomatosa. You have engorgement of the veins, thick veins, you have a pituitary enlargement, and you have a downward displacement of the brain to the skull base, so sagging of the brain. And believe me, there's almost no differential diagnosis if you have such an image in a patient with a GCS of 15, completely symptoms-free while lying down and complaining about a headache while standing up. Please look for the leak. Then you have spinal imaging, which is a little bit tougher to interpret. You have so-called spinal longitudinal extrathecal collections, SLECs, meaning you have extrathecal fluid in type 1 and type 2 fistulas. You see here this extrathecal fluid. This is not normal. Always look exactly where the leak is. You don't see where the leak is. You just see that there's extrathecal CSF on spinal MRI imaging. Then the next step is, again, neuroradiology based. You really need to have a dedicated neuroradiologist, someone who loves the disease as we do, who is really into finding the very exact site and height and level of the leak. And basically, this is a talk Lalani should give. I just briefly touched this. You need a dependent body position, and you inject the contrast medium while in parallel doing the images, whether it's CT or a myelo. It's not so important. You just need to see in the first run where the CSF exits or where the contrast exits the thecal sac. This is a movie now, and you see some artifact here in the diaphragm, and now you see the contrast coming along the spinal axis, and you see here this double contour. This is where the CSF exits through a leak in the dura, and this is the site of the leak. This is the normal thecal edge, and this is the epidural space, and here is the leak. So the very first second or parts of the second are important. And once again, you see here, this is the patient lies on his or her belly, and the head is down, bottom is up. So the contrast flows along the gravity, and suddenly you see another line, which is the epidural space. And you see here that the contrast is oozing out, and this is the very specific site of the spinal dural breach. And Lalani has given us a hint where to look for. And Lalani Carlton-Jones in her work showed us that this flow void sign here gives you a hint where to look for. And still in very experienced centers like in Freiburg, we still confirm this with a dynamic myelogram. But now we know where to focus on to reduce radiation dose to the patient and to have a higher yield for the myelogram. But this is a very elegant sign, and the yield of our examinations has gained a lot to do this work from Lalani Carlton-Jones. The same goes for type 2 leaks. So we need a dependent body position. You inject the contrast media while the patient is in the scanner. And Now you see the video again. You see the filling of the thecal sac, and suddenly there is filling of this cyst. And next to the cyst here, this is the problem, not the cyst itself. Next to the cyst, you see that CSF is oozing out through a tear in the dura. This is the same patient. Just you see the bone here again. And you see that here CSF is filling next to the thecal sac in the epidural space. And you know that this is a leaking cyst, or there's a tear beneath this cyst, because you might have patients with many of these diverticulars or many of these cysts. You always have to look for the actual leaking, the active leaking. This is key. Sometimes you have to do this in the CT scanner because there is some problems with the shoulders and you don't see the actual site of the leak. Now, coming again closer and closer to surgery, let's start with this spinal meningeal diverticulars or cysts. And my group has shown this in 2016 already, that the pathophysiology is not the cyst itself. The cyst that you see on imaging is just a try of the body to seal the leak. So it's nothing else but an outpouched arachnoid. And the problem is the tear in the dura, here most often very closely to the exiting nerve root along the spinal cord. And so here you can see the problem is the CSF oozing out next to the cyst through the dural tear. This is how it looks like in surgery. You have the thecal sac, you have the exiting nerve root, and most often in the axilla of the nerve root, you have this outpouched arachnoid, giving you this cyst-like appearance on imaging. And this is a patient that was operated on in the first 3 weeks, and you see now it's very thin, it's translucent. It looks like arachnoid. And why does it look like arachnoid? Because it is arachnoid. The tear is underneath here. This is the normal thecal sac. This is the exiting nerve root, and it's just an outpouching of arachnoid, and the CSF is oozing out next to this herniation. This is another patient, same lateral CSF leak, operated on a couple of months after symptoms onset. And you see it doesn't look like arachnoid anymore, but still it is just scarring and thickening. But the mechanism is the same. This is the exiting nerve root, that is a thecal sac. And here in the transition zone from the thecal sac to the exiting nerve root, there's a weak point, so to say. And here there was a breach in the dura and this outpouching of now scarred arachnoid. How to approach this during surgery? I show you a surgical video now where we do a minimal invasive approach. Here is the neurological finding. Then we use a small tubular retractor, 18 or 20 millimeter in diameter. We always do this microsurgically. And first you see the thecal sac, then now a little bit more lateral with the diamond. And this is a cyst. This is an outpouched cyst along here, in this case, along the nerve root. This is a thecal sac, and I just reduce it. This outpouched herniated thecal sac, I reduce it, and then you have the origin of the leak is this tear in the dura, and this patient it's at the exiting nerve root, and since it's a non-eloquent nerve root, I make a sleeve around it and clip it so it's really watertight. And we've done this many times. The patients feel better, symptoms stop immediately, and they do not complain about symptoms usually when you have clipped a non-eloquent thoracic nerve root. Niklas Lützen, again, we work together with Professor Lalali Carlton-Jones from London. They have published this year a wonderful bud on branch sign. It's like a bud on a branch of a plant. And if you find this on the heavily T2 weighted MRI, you have again a clue that this might be the most likely place or position of the spinal leak. And please, before going on with surgery, we need to do more research. At the moment, we still confirm it with a dynamic myelogram. This is an image, a drawing of in the wonderful publication by Niklas Lützen and Lalani. You see, these are the exiting nerve roots, and almost always, or most of the time, a little bit beneath the exiting nerve root. In the video, it was right on the nerve root sleeve, but then most of the times it's a little bit beneath the nerve root. You have just a simple, plain and simple tear in the dura, and the arachnoid is pouching out, giving you this bud-on-branch impression on imaging, and the CSF is oozing out next to this bud-on-the-branch that you can easily surgically ligate. The most often found pathology, at least in many centers, it really depends on the referral patterns, is the tiny little microspur at the level of the disc space, cutting the dura like a knife, like here on imaging. This is the artistic rendering, and you see again CSF is oozing out through the dural tear. And this is how you diagnose it. Most oftenly you find this a double contour because the contrast medium is flowing along the contour of the inner surface of the thecal sac, and then once you have this breach, you have another contour, you have this double contour. So it looks like on imaging, you have this double tram track sign here, and you know, okay, here is the start, here is the leak. It's not here. This is just where the contrast flows to. It's not where the contrast comes from, meaning it's not the leak, okay? Just focus on this center. Surgery for this is considered to be rather complicated or difficult. From the basic, it is because it's on the ventral surface. So how do we approach the ventral surface? And since I'm a trained tumor and vascular surgeon, removed a lot of carcinomas and tumors from the spinal cord, we knew how to handle the spinal cord. And I think the key step is cutting the dentate ligament and freeing the spinal cord. And you can then reach the ventral surface of the dura mater. I will return to that very important issue, and we can discuss that later. So in the beginning, we did hemilaminotomy, neuromonitoring the first 150 cases. But since we did not have permanent deficits, we stopped neuromonitoring. Cutting the dentate ligament is the key step. Then you free the spinal cord. You can rotate it a little bit. It's not necessary anymore. I show you an even more elegant way to reach the ventral surface. But from the principle, it is that you have access to the ventral surface of the spinal cord. This is an ancient historical surgical video, one of my first or the first surgical video. There I did a hemilaminotomy at that time, just over one level. And if you look very closely, you can see the origin of this disease. You can see here CSF oozing out. This is the disease. It's a CSF loss syndrome. Then I cut the dorsal surface of the dura, cut the dentate ligament. Here I grab the dentate ligament, and you can have access to the ventral surface of the spinal cord with this tiny little microspur. Remove the microspur, and then you have this oval-shaped, usually 2 to 6 millimeters long ventral cut in the dura. You can suture, and I show you an even more elegant way now how we handle this ventral leaks, and it's closed. Talking to neurosurgeons, there's always the discussion how to approach this ventral surface. And there are many ways to reach the anterior aspect. And usually it's even considered to be a contraindication to come from the back to the ventral surface. But I think it's very well possible. And we do not need all this very invasive anterior, transsternal, or lateral approaches, removing several vertebral bodies. I think it's not necessary. On the contrary, we, as a referral center, we receive many patients from other institutions that had extensive surgeries, like in this case, corpectomy over 2 levels in the cervical spine at the level 4 or 5, where almost never ever the leak is. So it was not found, it was just 1 level below, and you can really avoid and refrain from this 360 degrees multi-level approaches. It's not necessary. What we do now is this. We do a 2 centimeter skin incision, come from the dorsal side, use tubular retractors, and closed over 450 spinal leaks, minimal invasively like this, without, luckily, permanent neurological deficits. So the bony removal is just as big as a 10-cent coin. It's just it's even smaller than a 10-cent coin. It's just like 14 or 15 millimeter, and no weight-bearing structures are affected. And I guide you through the surgical steps now in more detail. Just to give you an overview, this is a quick video how this is done. This is not a typical SAH patient. She has had a body mass index of over 40. Usually the patients are very thin, and then it's extremely rare that you need 8-centimeter tubes to reach the spine. So, but you can do this, and then you need to use the microscope, cut the dura dorsolaterally, approach the ventral side, and you see this oval shaped, in this case, probably 3 millimeter long dural tear. The steps in detail: place the tubular retractor under fluoroscopy, and then the first step is to cut the dura. You open the dura in a disease where you want to close the dura, but this is just the access opening. You open it, and then the next step is really, this is the key step, to free the spinal cord, to cut the dentate or denticulate ligament, and then you free the spinal cord. The next step is to prepare alongside the lateral aspect of the dura and always pull the dura laterally. So there is no need to touch the spinal cord or to push it away. It's just you push on the other side. You push on the lateral dura and you bring the dural tear into your microscopic field of view. Usually the microspur is handled by this maneuver because it's really tiny. It's smaller than a corn of rice. And then you have access via the extradural route to patch it. There is no need more to suture it, because suturing below the spinal cord might be bothersome and time consuming. It's just enough to patch it with like Tachoseal, pinch it a little bit inside the dural tear, cover it with a second layer. You have a Tachoseal sandwich, and that's it. This is a surgical video. Cut the dura. You see the ventral dural tear. You excise the little tiny microspur, which is smaller than a corn of rice, very tiny, and like granola. And then you put it a sandwich from the extradural route. Again, open the dura. You see it intradurally, this yellow surface, extradurally, intradurally. Pinch it with the forceps into the tear, and just next step is cover it with a second layer, and you're done. No need to suturing. Just suture, of course, the lateral, the dorsal dural access opening. This is again such how it looks like. It's 3, 4, 5 millimeters oval shape. They all look the same, these dural tears, but they are different in sizes and in exact location. And afterwards, of course, you have to suture the dorsolateral durotomy, which is only like 8 millimeters in size. And again, you are neurosurgeons, you understand this. The key step is to lateralize the dura, to bring the dural tear into your field of view, and never ever to medialize the spinal cord. So there is no need to touch the spinal cord. And still, I think it's spinal cord surgery. It's not for orthopedic surgeons who do heavy material instrumentation. You need to know how to handle the spinal cord. Then you can do this type of surgery very fast, very efficient, and very safe. What we recently get to know more and more, that it is also a lot of membranes and the arachnoid membranes that form or herniate through these dural tears and actually do prevent the dura from healing. Usually, if you have a tiny tear in the dura of a couple of millimeters, it heals on its own. Why doesn't it heal on its own in spontaneous intracranial hypotension? Because of these membranes. They prevent the dural tear to heal. You have always these membranes that prevent the dura from healing together. And this is why transecting these membranes is one key step in surgery to get a good outcome for our patients. And if you look at the video I showed you once more and even more closely, you see it's covered here by membranes. It's not covered. It's a funnel. It's still open. Just because you open the dura and suck off CSF, they collapse, but it's still a funnel. It's like a vessel from the inside of the cecal sac to the outside of the cecal sac. And with the surgical procedure, you, of course, dissect and cut these membranes, and then it's really enough to cover the hole with a little bit of Tachoseal or something similar, that the dura now heals again on its own. There is no need to suture it. Again, consider the membranes. These membranes kind of must be there, because if you remember how the images look like, the MRIs, you have these slacks, and these slacks are confined. And how is water confined, CSF confined? There need to be a border, there need to be a layer, an arachnoid layer or whatsoever that confines the slack space. So these membranes are, I think, very important if you try to understand the pathophysiology of the disease and also the different ways of actions to treat the patients endovascularly or surgically or minimally invasively. Again, this is the image. These slacks here are confined. And how are they confined? By these membranes. Okay, now, once again, the principle of the surgery. This is a patient with a ventral type 1 leak, ventral dural leak. This is a tiny microspur. And it was referred to us after having had surgery in a major center in Europe. We see 2-level laminectomy. And it was patient was kind of paraplegic for a couple of days and weeks, recovered thankfully completely, but the leak was still open. And then you see the tiny little difference. This was the original opening, a long skin incision, 2-level laminectomy, and a frustrain approach to this leak. Our approach was just a little bit more to the side, and that's the key, that's everything. A little bit more to the side, leaving the lamina intact, leaving the facet intact. And if you look at it, this was how the patient came. This is the very side of the disease, and a little bit of, this is the actual post-op imaging, a little bit of removal of this tiny little bony structure is enough. Again, now with the microtube, now with the bone removed, and it only takes this 10 millimeter, 12 millimeter bony opening to reach the ventral aspect of the dura, as is shown here. And I think this is the key image. Only don't come from the midline, come a little bit from the side. 10 millimeters of bony removal is enough. And then you have a surgical trajectory to reach the anterior part of the spinal dura without even touching the spinal cord, and still release the spinal cord. Here is the dentate or denticulate ligament, cut it, and then the spinal cord can move to the side, and you have an even bigger root trajectory to your surgical target. This is the key image for me. Okay, then in 2014, again, the master surgeon Wouter Schiewing from LA, he found, together with Marcel Meyer, that there is a third type of leaks, and this is a direct connection from the endothelial compartment to the veins, a CSF venous fistula. And in the beginning, we had a hard time believing that this exists, and we had a hard time finding it in Europe. I think it took us 5 years in Europe to find the first CSF venous fistulas. And now it's kind of a standard procedure. It's a standard of care. It's very, not easy, but it's very straightforward if you know the tips and tricks. And if you have a neuroradiologist like Lalani or Nicholas that really are dedicated to this disease, they easily find the CSF venous fistulas now. And you see here in the CT, patient lying on the side, not on her belly now, on the side. And you see how the contrast is oozing out directly into the vein. This is a CT cone beam image. I always call this a piece of art, but done by Niklas Lützen in Freiburg. And you can see how the contrast is oozing into this diverticulum as a little fluid level and then flowing directly into the vein. This is so beautiful. And then we really know this is the site we can easily treat surgically. And it's done in a couple of minutes these days. So this is, of course, then also approachable via the endovascular route, and you can treat this by embolization neuroradiology. Walid Benjiki from the Mayo Clinic has done it first, and now this again, it is a kind of a standard procedure in centers, in CSF centers around the world. I can show you how these cysts, not cysts, sorry, these CSF venous fistulas look like surgery. This is a type 3 leak now. Again, you see how the CSF is oozing out into the veins. Again, the minimal invasive approach, 2 centimeter, a skin incision. Then I do not coagulate the epidural space to find the veins. The epidural space is nothing but veins. You see the thecal sac here and the exiting nerve root. And now you see this tiny little vein that is filling with some clear fluid here. But how can we really be sure that it is the fistula? So we injected sodium fluorescence, a dye, intrathecally during surgery at another level via lumbar drain. And this is normal, that the thecal sac fills and the exit of the nerve root fills. And now you see all the veins are red, apart from one vein. And this vein is filling with contrast. And this is the very specific CSF venous fistula, the fistula point. All the other veins are negative. It's just one tiny little connection that you can now easily coagulate and cut out like it's done here. It's a very fast and safe procedure. And it's also very effective done endovascularly. So complete improvement in 58% of the cases, in 40% of cases, partial improvement that was shown at the Mayo Clinic. It is very effectively and very elegantly treated, as again was shown by Lalani and Andrew Cullen together, that you can transcutaneously, you can glue it, CT guided with fibrin glue, very elegant way, very effective. You have cure rates of 60% and at least partial improvement of 34%. And in our surgical series, it's a surgery, but it's more effective. I think 98% of our patients have improved and 85% even very much to complete normal. So I think at this current phase, surgery is a little bit more invasive, but way more effective than embolization and transcutaneous procedures. But I'm sure they will get better and better, and we have plenty of alternative for our patients. When you have a dedicated neuroradiologist, you also find new stuff. As this is not a rendering, despite it looks so beautiful. It's a real actual image done by cone beam, ultra high resolution cone beam CT. And this is a very special case just to show you that there's nothing is known about SAH at the moment. We're just beginning to understand this disease. And this is a CSF lymphatic fistula. So the CSF flows not into veins, but into lymph vessels. And these lymph vessels are gathered around azygos and cava vein. And we've proven it later on in another series that is indeed the lymph vessels are not the venous system. Very curious, very intriguing. You can read now, 20 years ago, you could have published any case because it was a very, very, very rare disease. In the meantime, we know it's as often and as frequent as subarachnoid hemorrhage. Incidence is around 5 per 100,000. And you can find this in many, many review articles. These are just two, one focusing on the disease, one focusing on the search for the CSF leak. And basically, to keep it simple and to summarize it, we have clear findings in SIH. Do not neglect such MRI imaging with huge engorgement of the sinuses, round sinuses. There is convex sinus surface, downward displacement of the brain, positive spinal signs with slacks. Then you have the diagnosis. And then the next step is that you, apart from the diagnosis, you do need to find the leak. And this is where elaborate neuroradiology comes into place with all these dynamic studies I've shown you, and with the goal to find one of these three major leak types: type 1 ventral leaks, type 2 lateral leaks, and type 3 CSF venous fistulas. And then you have treatment. You do blood patching first, you do embolization or CT-guided transcutaneous fibrin glue, and you have a plethora of surgical tools to close all these three types of leaks. And it's already written together in a multidisciplinary consensus guideline how to approach these patients. And with that, I would like to point out that we have also, together with the help of Lalani Carlton-Jones, established Freiburg and Bern CSF visitorship. It's a 3-day course. You can come to our place. The course in March is already booked, but in November we have the next one. We do it biannually, so you are really invited to come to Freiburg. We show you cases, we do live surgery, and even more important, we do live diagnosis, myelograms, that you are able to find these leaks in your patients. And it's a very reasonable fee, I think only 200 euros or so. This is all due my fabulous team in Freiburg, Katharina Wolf, Amir El-Rachal, Florian Volz, and also, of course, neuroradiologist Horst Urbrach and Niklas Lützen, and Ms. Zander, and even even many disciplines and people around all over the world, like Lalani Carlton-Jones in London and Walter Schewing and Ian Carroll and many other people. We are a real family, I think, the CSF League community, and we have fun diagnosing and treating our patients, and it's very rewarding when we find a leak, close it, and most often our patients are better before the intervention than after the intervention than before the intervention. And surgery, I think, in the current stage is a one-size-fits-all, so to say, with a very tiny little skin incision. We have shown in hundreds and hundreds of cases you can approach all these type of leaks minimal invasively. And if it's a CSF leak, for instance, the surgical time skin to skin is only 40 minutes or so. It's a very elegant approach. So thank you so much from my side. I have no slide. We also do have a wonderful CSF League meeting in Amsterdam at the end of June this year, where you can, of course, also join. And with that, I'm again feel very honored to be a guest in your society. And thank you so much for your attention.
Jürgen, thank you so much for condensing what is clearly a huge topic so elegantly and eloquently. You have managed to cover all of diagnostics and treatment in a short space of time. And I wanted to perhaps discuss a few things with you that you've raised that may be educational for our audience. But I just want to first start off with saying that if anyone in the audience wants to learn more about this field, you should definitely go on this Beck visitorship. They have experts and people who are just starting alike, and everybody learns. I can't tell you how incredible it is to watch world-leading experts performing these procedures. They make it look very easy, and they're very welcoming, and you will learn a lot. So I would really advocate for people to go if you're starting out in your practice or if you're experienced. So perhaps I can, if it's okay, I can start by asking a few questions that I think might be good for this audience, which is, you've very clearly demonstrated that there are lots of neurosurgical approaches to the treatments of this, and for those maybe perhaps beginning in their practice or who aren't maybe seeing as many cases as perhaps the leading referral centers are, how can people looking to get more involved in this field engage with their team, recognize this more, and start off maybe increasing their volume of what they're seeing?
Thank you so much, Lalani, for your kind words. And you just hit the crucial spot, so to say. It is very important that you team up. This is not a disease for neurologists, not a disease for neuroradiologists and neurosurgeons, but for the team together. And I'm completely lost without you, without Niklas Lützen, without a radiologist. I cannot explore the spine over several levels. It's extremely dangerous and you do not do any good. You need to know 100% sure the exact level and side of the leak in order to be able to perform these tiny little elegant minimal invasive approaches. And it is a long journey. Probably I should have pointed more to the difficulties we had in the beginning, finding the leaks, bigger approaches. And we only got better, to be honest, when we worked together more and more closely with neuroradiology. So I sit together at the end of each day, I sit together with Niklas Lützen, Horst Urbach in the radiology suite. Sometimes I'm even doing the studies with them, and we look at the images second by second, where exactly is the leak. Otherwise, you're lost. So it's really a wonderful team approach. And please do not underestimate the surgical approach. You need to be a neurosurgeon and you need to be experienced with opening the dura and handling the spinal cord, of course. Thanks for that.
Yes, I absolutely agree. I would say, the wider team involvement is extremely important in this, and also for collaborative learning between disciplines and feedback on cases. So I think also you picked up right at the beginning on why it is so important to treat this disease. We've already seen there's several papers been published by yourself and also Deborah Friedman on the quality of life of these patients that is very severely impacted. Perhaps you can tell us a little bit, though, about patients maybe who undergo epidural blood patch. They're then very well, but their imaging shows us they still have a leak. What are the potential complications that can happen to these patients?
Perfect question, Lalani. Almost all patients do benefit from blood patching when assessed immediately after blood patching and when assessed the next day. And then the next day they are sent back home. And after a couple of weeks or months, you need to see and you need to follow your patients, because after initial phase of improvement, probably it's just pathophysiology. If you inject 40 cc's of blood in the epidural lumbar space, you kind of translocate 40 cc's of CSF from the spinal compartment to the cranial compartment, and you feel an immediate relief because your CSF is replaced. But you hardly really do close the leak with your blood patch, meaning after a couple of weeks or months, patients are still symptomatic, probably a little better, but still symptomatic, and you might experience long-term sequelae of spinal CSF leaks, meaning, for instance, superficial siderosis, severe brain sagging. Walter Schieving has done extensive work on that, and after 10 years or so, almost all patients develop superficial siderosis, which is also a kind of a treatable, or then better to say preventable, form of dementia if treated early on. So a spinal CSF leak is not harmless. It should be closed. And if you do a blood patch, it's completely fine. Not all patients need immediate jumping on with imaging and surgery. No. Don't get me wrong. They need a blood patch, and a substantial portion of patients get better, but follow them until they are completely back to normal, and follow them until the spine is slag negative and the leak is closed.
Absolutely. And that, again, brings in the involvement of the wider team and who's going to be performing the follow-up of these patients. You very elegantly showed the surgical techniques which you have pioneered. And again, you make look so easy. And just for those who aren't aware, Jürgen, University of Freiburg, Uniclinic Freiburg, and Bern put on an expert spinal CSF loss conference nearly 2 years ago now, and they live screened 5 surgeries in a very short space of time. So they did it, really efficiently, and I was really struck how efficient this was running, and they made it look very easy. But I want to really ask you, Jürgen, there aren't as many surgeons doing this work as we would like in this field. How are we going to find and train surgeons to be taking on this work and doing it well?
Lalani, I love this question. We do this. I think it's a stepwise process. It's because we have this wonderful invitation from the Asian Congress of Neurological Surgeons. Today, like this, we are able to inform our colleagues, and then we need to team up. And I think it's very well that if you do this for the first time, I think the Asian neurosurgeons are the best in the world, and they need to see 1 or 2 procedures, and then they can do it like the best experts. And we are happy to welcome you, to invite you, and to show how we're doing it, and then you can do it even better. But seeing it once or twice or 3 times would be, from my understanding, very helpful. And then you can perfect and even improve the system. And again, surgeons who are able how to handle and know how to handle the spinal cord, I think it's a doable procedure for them. It's not magic. It's straightforward. And we started doing it with monitoring. And if you are more and more secure, you can also include monitoring in the first place, and then you can do it more and more less invasive. And the same goes, I think, Lalani, for your peers, that if you show the tips and tricks, how to find, for instance, the first CSF venous fistula in Freiburg, because we had a hard time. And once we knew the tips and tricks shown us by Walter Schieving and Marcel Meyer and our colleagues in Duke, Peter Kranz, then it's not easy, but it's doable.
Yes, and it's important to add that the field of both surgery and techniques for leak localization is moving dynamically all the time. There's been an absolute explosion of papers that have been published in the last few years in particular, which are all adding to these iterative improvements in our pickup rates for these leaks and successes at treating them. And that can only improve with more people wanting to do this in the field. So I may be going to ask you one final question, and I'm sure others have questions. What do you think are the most pressing issues in our field that we need to address currently?
Raising awareness, being aware that this is not a harmless disease, and that many patients do have this disease and they have no help. I always ask myself, what happened to these patients 10 or 20 years ago? I don't know. And the more centers rise in the United States, in the United Kingdom, in Europe, in Italy, in France, and so on, they all are overwhelmed with patients. Though it's not that I can't help myself getting patients from all over Europe and all over the world, even now starting from Australia. There are so many patients out there that need our help. So raising awareness. And then second, teaming up. And the first team, you need to have a sibling, a team at your place. A neuroradiologist and a neurosurgeon is the minimum to start with. And then if you have a team and you are dedicated, then please join our conferences, our live surgeries, our sessions, your excellent papers and courses and online seminars. And then I'm sure that there will be many centers in Asia in the next years to come to treat many patients with this disease.
Brilliant. Thank you so much. I'm going to maybe ask the rest of the panel, will they have any questions? Ben?
Yes, and thank you, Professor Beck, again for these wonderful lectures. So, yeah, it's a pity that I just know that you have this visiting fellowship that I couldn't make a schedule for it. Then, but I do have some questions that about the management of disease. First is that in some center without the expertise as you have, sometimes we adopt a watch and wait and approach to this. So, so what do you think about the timing that you can observe, and whether this kind of the leaks like type 1, type 2, type 3 can heal spontaneously? And sometimes they give we encourage the patient to drink more coffee, and in old with the old wisdom about like the coffee and or even giving caffeine to the patient. So this is my first question. What do you think about this kind of the approach? And my second question.
Excellent question, Ben. Excellent question. And let me answer the first question, because I forget the first question if you ask another one. This was an excellent question. And there is currently we have more and more information how to handle these patients. And to give you a rough overview, first of all, the longer it takes for the patient to heal the leak, the tougher it gets to get really healthy again. So timing is an issue. And you do not need to treat them on an emergency basis, but I think the first blood patch should be given rather immediately. So let's say in the first week. Then you need to visit or to see your patient again after 14 days and do probably the second blood patch. And if there is no permanent healing in the first 4 weeks, you should proceed the patient to a center and start invasive imaging. Because we know that once you need more than 3 months for the leak to seal, it's the response of the patient is way worse. So timing is an issue, not an overnight emergency basis, but 3 months is a kind of a threshold. The patient should be well in the first 3 months, meaning giving and applying the first blood patches in the first weeks. And even if they tell you it's all good, I'm healthy, see them later, at least once after 3 months, if they really do feel well. And if it was, you expanded your question, what type of leaks? If you have a type 1 leak with a microspur still sticking in your dura, so to say, they almost never heal on its own. So type 2 leaks have a way higher success rate of transcutaneous procedures and blood patching and targeted patching than type 1 leaks. And we do not have real numbers about CSF venous fistulas. Even if you have closed the fistula, there might be a new one at another place. So basically, as a center like we are, we basically follow CSF venous fistula patients for a very long period of time.
I see. Thank you. This is a very good answer that enlightened me a lot. And my second question is about like the in your center. What do you think about the correct technique for the epidural blood patch? Because like for me in our center, so because of to avoid the risk, we always do like from the lower lumbar level to inject like as much as the autologous blood as much as possible until the patient have like the symptoms of the back pain, and then we stop. And but definitely, and then we will put the patient in the reverse translatable position, and then, but I know this hard to prove that we can seal the leak, but at least as mentioned by you, there is probably the improvement of the symptoms could be due to the displacement effect. So in your center, how would you do what is the technique that you think is appropriate or the best way to do this blood patch?
Another excellent question. I can briefly overview the technique, but because maybe Lalani can expand on this later, it's done by neuroradiologists, by Niklas Lützen and Horst Urbach and Ms. Zander in our place. And we basically do it under fluoroscopy. We add a little bit of contrast to the blood that we can clearly first prove that the needle is in the epidural space, that we are in the safe side, and a little bit of contrast injection. And then we inject, as you said, as much blood as possible. So probably if it's a first time epidural blood patch in the lumbar space, 20, 30, 40, even 50 cc's until the patient complains about some tingling and numbness. And it's a very, very safe procedure. I think we've done thousands of blood patches now, and we have no single meningitis, no proven arachnopathie from this procedure, and so it's the severest complications have been a little bit of back pain overnight and leg pain overnight, but no permanent deficit. So very safe procedure if done properly, if done under fluoroscopy, and you know exactly where your needle is. And then, as Lalani has pointed out, there is a tremendous gain of knowledge what kind of percutaneous procedures you can do. And probably Lalani can answer this, that you have targeted blood patches, fibrin glue patches, patches for certain types of leaks. They get more and more effective. Maybe Lalani, you can jump in.
Yeah, so just to echo what Jürgen has said, we do all of our patches under imaging guidance. I think a lot of patients are often worried about this feared complication of arachnoiditis, because when you Google epidural blood patch, this is what the thing that's going to come out. This is, and that's often because I'm sure these patches were done without imaging guidance. You can use either fluoroscopic guidance or CT. We use CT, but it really is what is your neuroradiologists have the experience with, and we do. Jürgen described it perfectly. He's a neuroradiologist as well. How we do these, I think it's important to note that we don't have very good evidence. That's the main thing. We don't have great evidence at the moment for non-targeted epidural blood patching, and I'm sure more will come to light. There are places where it is certainly useful and successful, particularly for symptomatic improvement, and particularly for patients, I think, that are unwell with acute SIH. Like Jürgen said, those early critical periods. We find that really within that early critical period, that can be very useful, particularly for sick patients, which you will all encounter, because you'll have patients that come in with acute subdurals that will be secondary to leaks. But find that if we're still in that early period and we have then located the leak, then we can adopt more of a targeted blood patch or blood and glue approach, depending on the type of leak that we have. But also, we don't have great data about it. We have done a multi-center retrospective study on patching for CSF venous fistulas. But that again, it's retrospective data. We need better data basically on what is going to be the most effective treatment. And sometimes at the moment we are adopting this on an approach of what is the center expertise, what is the right thing for the patient. It may be that they're very well, it may be that they've had symptoms for a long period. Surgical repair has so far come out as having the most definitive treatment success rates, and in an experienced hand like Jürgen's, you would want to go to a surgeon like this, and they would give you a very high cure rate pretty much immediately. But we don't have that widespread experience yet, but it will grow. I think we'll have more data that comes to light about targeted and non-targeted patching soon. Jürgen, do you want to, just because we touched on this very briefly, I don't know how much time we have, but about subdural hemorrhage and SIH, because I think this is a real key area for neurosurgeons to recognize.
This is also has been recognized in the last years that if you have young patients with chronic subdural hematomas, young patients with bilateral chronic subdural hematomas, please immediately look for the leak. In a patient younger than 60 years of age and bilateral subdurals, you have an almost 50% chance of finding a spinal CSF leak. But very important, of course, if you have a symptomatic chronic subdural, relieve the subdural first. It's not that you play tricky games and finding some, for the first time, spinal leaks. If you have a large, like 2 centimeter or bigger subdural hematoma, of course, make a burr hole, but then do not forget to look for the leak. Many young patients have spinal leaks, and interestingly, all type of spinal leaks, even CSF venous fistulas. And we've now have some data on all the patients in Freiburg, even older patients where the prototype history is mild head trauma, even they, to a substantial amount, do have spinal leaks, even spinal CSF venous fistulas. So there is still we don't a growing body of evidence about SIH, but there's lots more to come in the next years. I'm so sure there's lots to come.
Right. Thank you very much. It is a very interesting discussion, and I think we can go on. But I'll just tell you my story, just a brief one. After the lecture that we had from Prof. Wolf and you chaired it, Prof. Jagan, and our center is one of the largest centers in the southernmost part of India, and we do thousands and thousands of chronic subdural hematomas. So after your lecture, we had one patient who was supposed to be operated, a bilateral chronic subdural hematoma, but unfortunately, because of the high volume of road traffic accidents on that night, we couldn't operate. And in the morning, I happened to see this patient, and I just asked him what is the problem, and she said her problem is she cannot sit up. She has severe headache while sitting up. So that's when it struck me actually. So we asked for an MRI. All the findings of SIH were there, and we treated her with a 20 cc of non-targeted blood patch, and as you said, and Viola, it's gone. She is perfectly normal. So I was really surprised. This is the first time that it has ever happened in our institution. As you said, that awareness is the thing, that we are not aware of this thing. Once you are aware, of course, we start to look at what is wrong. So thank you very much. I am really indebted to you guys for accepting our invitation and letting us know about the technical nuances and the diagnosis of this disease. If there are any questions from Dr. Libun Singh.
Thanks, Raja. Thanks, Prof. Just a short question, Professor. Regarding the dynamic CT myelogram, do you think that those patients post-traumatic injury with sunken flap syndrome, post-craniectomy, will be one of the indication, because this is the unresolved phenomena? Second one, a treatment for benign intracranial hypertension, including creating a CSF venous fistula. So how do we find the balance? Thank you, Professor.
These are high-end questions. I think the problem of the sinking skin flap is also a kind of a SIH topic. And Walter Schiewing, again, has published recently about this very interesting and intriguing disease. And we do know that patients get way better once we replace the bone flap. I think it's a kind of reversed SIH. And we do have the orthostasis-dependent brain sagging and displacement of the brain, which is not good for the brain. So we know as neurosurgeons that replacing the bone flap is very important. It's also very important from this brain sagging point of view, and even probably doing it properly with closing all of the cranial walls and don't leave big gaps behind. So I think this is something that will come in the future, how important this is. And the second question was?
Treatment for benign intracranial hypertension is creating
this is so intriguing, because of course the prototypical SIH patient is tall and thin and has low pressure, but we have more and more patients that fits into the prototype of idiopathic intracranial hypertension, high pressure. And some of these patients kind of relieve their pressure with a leak, either through the skull base. We have these tiny little herniations at the temporal base of the brain, causing epilepsy and rhinorrhea. And we have patients, and these patients have more spinal diverticula. And Peter Grant showed that the number of spinal diverticula is kind of loosely related to the likelihood of having a spinal CSF leak. So the more diverticular, the higher the chances that you get a CSF leak. And I personally do believe that the underlying high pressure is predisposing to a spinal leak. There is no good data for that yet, but the thinking is very, very logic, and I completely agree to you. And then we have the dilemma, what to treat and how to treat. But I'm very convinced that we should not leave it as it is and say, oh, now the intracranial hypertension has a leak and it's healed. No. We should keep it simple. A leak does not belong into a patient. We know there are chronic sequelae, there is siderosis. So we need, even in a hypertensive patient, intracranial hypertension, we need to close the leak. I'm convinced about that. And then we need to tackle the other disease by weight loss, by finding sinus thrombosis, and so on. So step by step, do not combine these diseases and say they are fine. Treat both diseases.
Thank you very much, Professor.
Thank you. Before we close, there is a question in the chat box just for completion. Do you have missed levels, especially in the dorsal spine? What do you do? Like, in other words, I would like to ask you, how do you find exactly the site of leak? Do you use some neuronavigation or image guidance?
During surgery, the tough part is finding the leak in the radiological studies. And then we clearly can count the level. It's, for instance, type 1 leaks are almost always between the vertebra 1 and 2 of the thoracic spine, or 2 and 3. And then we need to count it during surgery just with simple fluoroscopy.
That is the most difficult part, because we have difficulty even to find tumors sometimes. We have levels, especially in thoracic.
I completely agree. It's tough. And even we have do wrong level surgery, of course. And again, Lalani has found a very good help for the surgeons. I think Lalani is placing a little piece of gold at the lamina where the leak is. And we currently count it under fluoroscopy, but maybe we use the tip and trick from Lalani and to install a little piece of gold to find it faster and more safely.
Right.
We do that at the time that we do the myelography, if we think that's going to happen.
Fine. Thank you very much. So we'll conclude this session and have your concluding remarks.
Well, I think Jürgen Beck, he has been very modest, but I just want to also highlight that he and his team have published so many papers in this field that really you should go and read, but because they have informed our understanding of this disease, and how we work up and manage these patients. You just Google his name and you will find many of these papers which you should go and read. And hopefully, I think he has definitely inspired you and the audience to look out for these cases more and to hopefully know where to start and engage your team with carrying this. So thank you, Jürgen, for educating us so greatly on this.
Well, thank you very much. We are really indebted to wonderful work that you have done, Prof. Beck and Professor Jones. And now we'll wind up this session, and I'll hand this podium over to our Honorable Chair, Professor Tsutomu Ichinose, and who will say a short introduction and invite Professor Tao Wang for his lecture. Prof. Ichinose.
Yeah. Good morning and good afternoon and good evening. Actually, thank you for the invitation. This webinar, Professor Kato and Professor Raja and Professor Liu. Thank you for your invitation. Actually, this is my first visiting of this webinar, and I'm looking forward to learn this lecture from the Dr. Tao Wan. His topic is complex bypass, and the complex bypass is now, the decreasing the chance because the IVR, the case of the IVR increasing in the number in Japan. Especially for the young neurosurgeon. The experience of the complex bypass is remarkably decreased in the case. So I'm looking forward to learn Dr. Tao Wan lecture today. So please start the presentation. Please start the Professor Dr. Tao Wan. Please start the presentation.
Thank you for your introduce myself. It's second time I visited the webinar. I'm Wang Tao, Professor of Neurosurgery from Peking University Third Hospital. I specialize in surgical treatment of cerebral vascular disease, focus in ischemic cerebral vascular disease, especially carotid artery disease and carotid-related disease. Thanks for Professor Yoko Kito, the president of ACNS, for inviting me again to share my innovative work. In the past decade, my team and I have been working to carotid disease, such as carotid stenosis, carotid occlusion, extracranial aneurysm, and carotid body tumor, and so on. Well, my topic is complex extracranial bypass, indications and techniques. Complex extracranial bypass, indications and techniques. I have about 5,000 cases of carotid endarterectomy, CEA, and more than 400 cases of carotid body tumor, CBT, surgeries. And complex extracranial bypass indications, including 1. Lung segmental occlusion of large vessel. 2. Extracranial aneurysm. And 3. Carotid body tumor. Part 1. Most lung vascular occlusion can be performed directly by CA without bypass. ICA occlusion is more common than CCA occlusion. And we can see case 1. This is a 71-year-old man, and complete ICA occlusion is difficult to reopen. In fact, the reason for recognition is residual cavity at the distal end, like this. And remove a lung plaque is very hard. And the ICA was reopened after surgery. From its CTA, preoperative CTA, we can't see the distal ICA. And post-operative CTA, we can see reopened. CCA occlusion is less common than ICA occlusion, with lower residence. Most cases of lung CCA occlusion can be recognized directly through surgery, which account for 8%. The incidence of left side CCA occlusion is higher than that of right side. Etiology: Anterior sclerosis is the common cause. Thrombosis can often lead to occlusion. In our practice, we found that intraplaque hemorrhage present in most cases of CCA occlusion, probably the region of occlusion. Symptoms: most of our cases of common carotid artery occlusion are symptomatic, presenting with transient amaurosis, transient ischemic attacks, or strokes on the affected side. Some with chronic occlusion may exhibit symptoms of chronic cerebral ischemia, or may be asymptomatic. Treatment: the surgery of common carotid artery occlusion depends on whether there is a true lumen in the distal artery and whether it is truly occluded. Whether carotid endarterectomy or bypass is used. The most important factor is depend on whether the distal ICA is occluded. Bypass, such as subclavian artery to common carotid artery or subclavian artery to internal carotid artery, may carry a higher surgical risk than conventional CA. The surgery is also more technically challenging. And the CCA occlusion, direct CA surgery. Let's say case 1, it's right common carotid artery occlusion. It's a 73-year-old man. We can't say right CCA, pre-operative CTA. Pre-operative ultrasound indicate no blood flow, and pre-operative DSA, no blood flow. And when removed the lung plaque, it's a skin incision, a lung more than 10 centimeter, and the post-operative ultrasound showed that the blood flow was smooth. We can compare before and after surgery. We can't say right CCA, and we can say right CCA, post-operative CTA. Case 2 is right common carotid artery occlusion 2. We can't say right CCA, pre-operative CTA, and when remove the lung plaque, the plaque, we can see the hemorrhage. We can compare before or after operation. We can't say right CCA, and we can see right CCA. Case 3 is left common carotid artery occlusion. Hybrid operation, pre-operative CTA and CTP. We can't say left CCA, and preoperative CTP showed left side hyperperfusion, and preoperative HRMI, we can see the we can see CCA with hemorrhage, and when we remove the lung plaque, we can see intraplaque hemorrhage. Immediately after operation, a stent was placed at the lower segment to prevent restenosis. So it's hybrid operation, CA with CAS. Post-operation, we can see stent lowers CCA. We can compare pre-operative and post-operative CTP, the blood flow, time to peak, mean transient time, and Tmax. Post-operative significant improvement in CTP. Part 2, complex extracranial bypass indications. Only a small number of CCA occlusion can be reconstructed through bypass to restore blood flow, which accounts for 20%. The lower segment of CCA was stented and cannot be used for recognition directly. Common carotid artery occlusion caused by arteriitics, radiotherapy, intraplaque hemorrhage, fibromuscular dysplasia, dissection, aneurysm, and trauma. Carotid artery involved and damaged by the carotid body tumor. Ipsilateral carotid subclavian bypass grafting, CISBG. If the CCA is too narrow, or if there has been a previous dissection or stent placed in the middle or lower segment, an artificial graft can be used for carotid subclavian bypass. This refers to procedures such as subclavian artery to common carotid artery or subclavian artery to internal carotid artery bypass. Artificial vessel character including thin vessel wall, flexibility, hyaluronized coating, supporting design. Why we didn't use a great Cephorus vein? The great Cephorus vein cannot withstand long-term high pressure and requires another wound. Let's see case 1. It's a 67-year-old man. 9 years ago, the patient was designed with aortic dissection aneurysm due to sudden chest pain. And at the same time, dissection was found involved the right common carotid artery. So the lower common carotid artery can't be used. So we performed carotid subclavian bypass to reconstruct the blood flow. We can see artificial vessel graft and the subclavian and bifurcation is skin incision, 2 incision. It's my surgical plan. We use artificial vessel to connect subclavian to bifurcation of right CCA. And post-operative 3 hours, there is no numerical defection. Post-operative of CTA, we can see the bridge vessel. So a letter of thanks written by the patient when he was discharged. Case 2 is right CCO. This is a 65-year-old man. We can see right CCA occlusion and HRMII display hemorrhage in the plate. Bypass here. And the post-operative CTA, we can see the bridge vessel. And case 3 is a left common carotid occlusion. It's a 56-year-old man. The left carotid, common carotid occlusion. Left subclavian artery was low and flat, so that it was difficult to explore. The patient repaired the tile, and the tile exploded, and the left CCA was blown off. 6 months later, the patient came to our hospital and asked for operation. Pre-operative CTA and HRMRI. So we use artificial bypass. From here, bypass to the bifurcation. Pre-operative CTA and post-operative CTA, we can see the bridge artificial vessel. And the case 4 is right CCO again. It's a 67-year-old man. We can say the distal ICA is very narrow. And when we use artificial vessel bypass, the ICA became wider. We can see 2 skin incision. This pre-operative CTA is right CCO again. Is a 49-year-old man. He had a transient amaurosis and dizziness. And intra-operation, 2 skin incision, subclavian, common carotid artery. We can see the bridge artificial vessel. Pre-operative CTA and post-operative CTA, we can see artificial vessel before or after operation. We can see stem 1 anastomos the artificial vessel to the subclavian artery. It's artificial vessel, subclavian. Step 2, CA. Then the artificial vessel passes through the subcutaneous tunnel from the subclavian artery to reach the bifurcation of common carotid artery. Step 3, anastomose the artificial vessel to the bifurcation of a common carotid artery to reconstruct blood flow. Case 6, a right carotid, a common carotid occlusion, is a 6 to 1 year old man, and there is a transient amaurosis, left limb weakness. We can see right CC occlusion, and after surgery, we can see the artificial vessel from right subclavian to right bifurcation of common carotid artery. And case 7 is a case of left common carotid occlusion. It's 54-year-old female. We can't see left CCA. And preoperative HRMII displayed hemorrhage in the CCA. So after operation, we can compare preoperative CTA and postoperative CTA. Case 8 is right common carotid artery again. It's a 63-year-old man, and we can see right CCA occlusion. And HRMII can see hemorrhage. And after surgery, we can compare right CCA and occlusion and artificial vessel bridge here. And case 9 is right CCO again. It's a 48-year-old man, right CCA occlusion with calcification. With calcification, very various. So we use bridge artificial vessel to connect subclavian to bifurcation of CCA. Case 10 is a right CCO again. It's 66-year-old man, and we can see right CCO occlusion. It's bridge vessel. Before and after operation, we can see the path of CCO. And case 11 is left CCO again. It's a 54-year-old female, and left common carotid artery occluding. It's bridge vessel from here to there. Part 3, cross midline. Cross midline CSBT. Once CCA occlusion on one side, the ipsilateral subclavian artery occluding 2 bypass from the contralateral subclavian artery to the ipsilateral ACA is required, referring to as cross midline CSBT. The procedure involved anastomosing the artificial graft from the contralateral subclavian artery, creating a subcutaneous tunnel to the bifurcation of the epilateral ICA and then anastomosis the graft to the artery, like this picture. The left, let's see the case 12. Left CCO. The left common carotid artery, the left vertebral artery, and the left subclavian artery was occluded. There is no available blood vessel on the left side. Can we use right subclavian artery? So I went to a stationery store to buy colored pencil and designed a surgical plan. Step 1, anastomose artificial vessel to right subclavian artery. Step 2, how to cross midline to raise left bifurcation of CCA. Step 3, anastomose artificial vessel to the bifurcation of left CCA. If crossed the midline subcutaneous, it is easy, but patient can touch the artificial vessel because it is very hard. So we decided artificial vessel crossed midline through preventable space from the subclavian artery to raise the bifurcation of left CCA. A new question arisen. Well, it affects swallowing food. We can say the skin incision are 2 skin incision, the artificial from the right subclavian cross midline to the left bifurcation. And 6 months after surgery, we take a neck CT. The artificial vessel was located exactly in the prevertebral space, like this. So the artificial vessel happened to be on the path we designed before the surgery. From the right subclavian and the cross midline to the left bifurcation is past artificial. And there wasn't new cerebral infarction after surgery. Pre and post-operative MRI with DWI, and the pre and post-operative CTP. We can see the patient.
你这是什么饺子？饺子。带一下的。没问题。看来再敬口酒也没问题。
It seems that there is no problem to drink some wine.
你这是什么？
Cross midline CSBG2, CCA to CCA bypass. Connect the CCA with contralateral CCA by artificial vessel bypass. Let's say case 13. Left common carotid occlusion is a 53-year-old female. The left CCA occlusion and the left subclavian occlusion. So we use artificial vessel from right CCA to left CCA, cross midline. Post-operation, we can say CTA from right to left. And the CTP improvement. Part 4, Indication, blood vessel destroyed by carotid body tumor, very hard carotid body tumor. Case 1, the patient with CBT and the ICA and ACA was encased and destroyed totally by the CBT. This was a complex carotid body tumor surgery. The tumor was very hard. When we focus on separating the hard tumor, the distal ICA was broken. What should we be? Use artificial vessel? The broken ICA was too narrow, while the artificial graft was too thick. They didn't match. So we use ECA to anastomose. First, temporarily clip the distal end of internal carotid artery. Next, ligate and cut the distal end of external carotid artery. Replace the ECA inferior to the hypoglossal nerve, and then perform the anastomosis between the ECA and distal end of ICA to ensure intracranial blood supply. We can compare preoperative and afteroperative CTA and HRMI. The hard tumor was removed. ICA was recognized postoperative. Case 2 is another CBT. A giant CBT destroyed the sky base and invaded a pharyngeal cavity. Very, very large. And when we remove a carotid body tumor, we used artificial bypass. A mass in pharyngeal cavity can be seen through open mouth. Very giant CBT and post-operative HRMI, the CBT is removed. Part 5, indication extracranial bypass to treat extracranial aneurysm. Case 1, we can see a giant circulated aneurysm. And the aneurysm, we can see the worm is very thin. Artificial vessel bypass is another extracranial aneurysm. And DSA and HRI, MRI, we can see the big aneurysm. And intraoperation is skin incision, and the aneurysm was removed. Extracranial aneurysm, artificial vessel bypass, and post-operative CTA. Conclusion, extracranial bypass surgery can treat some common carotid occlusion, which cannot be performed directly by CEA. Indications for complex extracranial bypass include long segmental occlusion of large vessel, extracranial aneurysm, carotid body tumor. The common cause of these indications are stenting, arteriitics, intraplaque hemorrhage, dissection, aneurysm, trauma, blood vessel destroyed by tumor, radiotherapy, fibromuscular dysplasia. We use techniques SP lateral carotid subclavian bypass grafting, cross midline bypass, and direct bypass. And the indication, we also developed the other giant extracranial aneurysm, like this. And post-surgery, we can see the remote aneurysm wall and thrombosis. Another highlight is that we performed more than 400 carotid body tumor surgeries in recent years. There are more than 100 cases every year. We performed 185 surgeries for carotid body tumor in 2024. Carotid body tumor is a real disease. Its incidence is 1 in 100,000, but in our center, it become a common disease. It should be the center with the highest annual surgery volume for the carotid body tumor in the world.
吃饭喝水怎么样？吃的也很好，早晨吃了2个鸡蛋，一个冰板，一碗粥，很好。
The giant tumor was removed. ICA was patent. No neurological defect. That's all. Thank you very much.
Thank you for your great lecture, Professor Wang. I did not expected that such a wonderful lecture. I have never seen such a disease, so I actually wondering how to treat such a disease. Thank you for your lecture. I have several questions. First of all, which side of the artificial vessel is how do you decide which size of the artificial vessel for the reconstruction of the CCA, the diameter of the artificial vessel?
The artificial vessel, the diameter is about 6 millimeter. But in Asian patient, the ICA is very narrow, about 4 to 6 millimeter. So sometimes it doesn't match. But we can use artificial to narrow the artificial, and we can cut distal ICA and to widen the ICA, and then connect the ICA to the artificial vessel.
So you shape cut the ICA and make a fish mouth or some adjustment of the diameter of the ICA to the artificial vessel.
Yeah.
Okay, thank you. And the next question is, what is the suture material of the artificial vessel and the original arteries? What is the suture material?
What do you mean, the artificial or what material?
Material for the suture, the nylon or the Gore-Tex or string of the needle and the string for the suture.
I think the material I use the artificial is made in Gore company. I think it's nylon. Yeah, Gore.
Gore, yeah. PTTF. Yeah. I see. The material is the same as the artificial vessel. It is a technique for the vascular surgeon. I know. Okay. And the next question is you made a cross bypass, and the patient have no I looked the video. The patient has no apparent dysphagia immediate after the operation. What is the tips to make a subcutaneous tunnel just front of the vertebral body? Are there any tips to make a cross subcutaneous tunnel?
This cross midline and from two incision, and we use the artificial vessel connect subclavian, and we use two fingers.
Two fingers.
Yeah, two fingers to connect. So we put the artificial vessel from the subclavian incision, subcutaneous, and then to the bifurcation of the CCA. So finger to finger.
So you enter just the medial side of the carotid sheath and feel the vertebral body, both sides, and make a subcutaneous tunnel with the finger.
Not from here. It's incision, and the artificial from the subclavian incision to here, and then the finger to finger prevertebral space.
Prevertebral space.
Along the vertebral space, and the finger to finger, touch the finger to finger, and then put the artificial to the bifurcation.
So
it's easy.
How to? So you have no risk of the injure the vagus nerve?
Never.
No.
No. Thank you.
Okay. Thank you for your great lecture. Are there any additional comment or question from the audience?
Ben?
Thank you very much.
Yes, and hello, Professor Wang, and thank you so much, and congratulations to your result. Personally, I watch your WeChat channel as well, and really impressive results about your carotid surgery. Professor Ishino asked a lot of questions that I want to ask, but I have one more question is about those cross midnight bypass. So how can you decide the length for the artificial graft? And despite the swelling problem, do the patient have the problem when they turn the leg?
If the artificial through the subcutaneous, when you turn your neck, the artificial perhaps rupture. So we through the prevertebral space. It's the shortest, and it can control yourself. So I think through prevertebral space is the best way. And first, at the beginning, I'm afraid of it affect swallowing.
Yes.
But from this patient, you can say it's nothing.
But how long you need the graft? How can you know? How long?
I think about 10 centimeter. More than 10 centimeter.
I see.
So you mean the 10 centimeters from one side to one side, the 10 centimeter? right side to left side. The transverse distance is 10 centimeter.
The length depend on the occlusion length. And the gore artificial vessel is very long. I think it's about 50 centimeter. So you can cut as you please.
Nice. Thank you so much, and really impressive, and hope to learn from you in the future. Thank you so much.
Thank you.
Thank you,
Professor Ben.
We can take the final remarks from Prof. Ichinos. You can say your concluding remarks, Prof.
Okay. So now I grow the I growth.
Yes, please.
Yeah. Thank now in these 3 days we have in Japan we have a Japanese stroke conference. So I have very hard schedule, but I actually enjoyed this webinar. Thank you so much. I will come again. I want to come again this webinar. Thank you for invitation, Professor Raj and Professor Liu. And actually, I want to say thank you for the Professor Wang. Please come Japan again, and please come Japan. And I want to learn from you the more complex bypass techniques. Thank you very much, every members for the ACNS. Thank you for your comment.
Thank you very much. We indeed had a great time learning from Professor Wang. Thank you very much, Professor Wang. So I'll close this officially now on behalf of the Education Committee of the ACNS and the President, Prof. Yuko Kato. I would like to thank both the speakers of today, Professor Jason Beck and Professor Tao Wang, as well as the chairs, Prof. Narani Carlton-Jones and Prof. Sutomu Chinose, for the time and support for the ACNS webinars. A special thanks to Professor Shubin for broadcasting this webinar on the WeChat channel, and special thanks to my co-host Dr. Liu Bun Seng and Dr. Ben, who joined from Malaysia and Hong Kong respectively. So until we all meet online tomorrow, it is bye-bye from all of us. Thank you very much for joining.